In this video, we will be covering rheumatic endocarditis. Rheumatic endocarditis, otherwise called rheumatic heart disease, is a condition where the heart valves have been permanently damaged by rheumatic fever. The heart valve damage may start shortly after untreated or undertreated streptococcal infections such as strep throat or scarlet fever. An immune response causes an inflammatory condition in the body. This can result in ongoing valve damage. Acute rheumatic fever occurs most often in school-age children, may develop after an episode of Group A beta-hemolytic streptococcal pharyngitis. Patients with rheumatic fever may develop rheumatic heart disease as evidenced by a new heart murmur, cardiomegaly, pericarditis, and heart failure. Rheumatic endocarditis is an acute, recurrent inflammatory disease that causes damage to the heart as a result to Group A beta-hemolytic streptococcal infection, particularly the valve, resulting in valve leakage or obstruction. There are associated compensatory changes also happens in the size of the heart chambers and the thickness of chamber walls. The causes of rheumatic heart disease. Rheumatic heart disease is caused by rheumatic fever. Rheumatic fever can occur at any age. The streptococcus is spread by direct contact with oral or respiratory secretions. Although the bacteria are the causative agents, malnutrition, overcrowding, poor hygiene, and lower socioeconomic status may predispose individuals to rheumatic fever. Untreated or undertreated strep infections can increase the risk for rheumatic heart disease. Children who get repeated strep throat infections are at the most risk for rheumatic fever and rheumatic heart disease. And also those who are living in overcrowded or unsanitary conditions are at risk for developing rheumatic heart diseases. Now we will see the pathophysiology of rheumatic endocarditis. Bacterial infections called Group A streptococcal infections can cause rheumatic fever. An infection like strep throat or scarlet fever triggers the body's immune responses, causing inflammation throughout the body, including in the heart. Rheumatic fever causes rheumatic heart diseases. It is heart valve damage. Mainly the mitral valve are affected. The heart valves can be inflamed and become scarred over time. The heart damage and the joint lesions of rheumatic endocarditis are not infectious in the sense that these tissues are not invaded and directly damaged by destructive organisms. Rather, they represent a sensitivity phenomenon or reaction occurring in response to hemolytic streptococci. Leukocytes accumulate in the affected tissues and form nodules, which eventually are replaced by scar tissue. Rheumatic endocarditis anatomically manifests first by tiny translucent vegetations or growths, which resemble pinhead-sized beads arranged in a row along the free margins of the valve flaps. These tiny beads look harmless enough and may disappear without injuring the valve leaflets. More often, however, they have serious effects. They are the starting point of a process that gradually thickens leaflets, rendering them shorter and thicker than normal and preventing them from closing completely. The result is leakage, a condition called valvular regurgitation. The most common site of valvular regurgitation is the mitral valve. In some patients, the inflamed margins of the valve leaflets become adherent, resulting in valvular stenosis, a narrowed or stenotic valvular orifice. Regurgitation and stenosis may occur in the same valve. The function of the valve is to keep the blood flowing in the right direction throughout the heart. But inflammation from rheumatic fever can lead to permanent damage to the heart valves. Damaged valves reduce the amount of blood that can move through the valve. This makes it harder for the heart to work normally. They also may allow some blood to go in the wrong direction. The myocardium is certain to be involved in this inflammatory process. Rheumatic myocarditis develops, which temporarily weakens the contractile power of the heart. The pericardium also is affected, and rheumatic pericarditis occurs during the acute illness. These myocardial and pericardial complications usually occur without serious consequences. Rheumatic endocarditis, however, results in permanent and often crippling side effects. Compensatory changes in the chamber sizes and the thickness of chamber walls occur. This may take years to develop and can lead to heart failure. What are the symptoms of rheumatic heart disease? Symptoms of rheumatic fever may vary. They typically start 1 to 6 weeks after about a streptococcal infection. In some cases, the infection may have been too mild to be recognized, or it may be gone by the time the person sees a healthcare provider. The most common symptoms are fever, swollen, tender, red, and very painful joints, lumps under the skins. Patient may have a red raised lattice-like rash, often on the chest, back, and belly. Shortness of breath and chest discomfort may be present. Patient may have uncontrolled movements of arms, legs, or facial muscles. Patient may be weak. Symptoms of rheumatic heart disease depend on the degree of heart valve damage and may include shortness of breath. It is very often with activity or when lying down. Patient may have chest pain, fatigue, heart murmur, swelling in the stomach, hands or feet, palpitations or cardiac arrhythmias like atrial fibrillation. Patient may have coughing up blood. A few patients with rheumatic fever become critically ill with intractable heart failure, serious dysarrhythmias, and pneumonia. These patients are treated in an intensive care unit. Most patients recover quickly. However, although the patient is free of symptoms, certain permanent residual effects remain that often lead to progressive valvular deformities. The extent of cardiac damage or even its existence might not have been apparent in clinical examination during the acute phase of the disease. Eventually, however, the heart murmurs that are characteristics of valvular stenosis, regurgitation, or both become audible on auscultation and in some patients even detectable as thrills on palpation. Usually, the myocardium can compensate for these valvular defects very well for a time. As long as the myocardium can compensate, the patient remains in apparently good health. With the continued valvular alterations, the myocardium is unable to compensate, as evidenced by signs and symptoms of heart failure. Usually, the mitral valve is most often affected, producing symptoms of left-sided heart failure, shortness of breath with crackles and wheezes in the lungs. The severity of the symptoms depends on the size and location of the lesion. When a new murmur is detected in a patient with a systemic infection, infectious endocarditis should be suspected. The patient is also at risk for embolic phenomenon of the lung, kidney, spleen, heart, brain, or peripheral vessels. How is rheumatic heart disease diagnosed? They may have a murmur or rub that may be heard during a routine physical exam. The murmur is caused by blood leaking around the damaged valve. The rub is caused when the inflamed heart tissue move or rub against each other. Along with complete health history and a physical exam, tests used to diagnose rheumatic heart disease may include a throat culture or blood test may be used to check for streptococcal organisms. Certain blood tests may be used to look for infection and inflammation are sedimentation rate, WBC count and differential, and CRP. These may be increased during acute phase of infection. There can also be elevated antistreptolysin or ASO titer. Cardiac catheterization is used to evaluate valvular damage and left ventricular function in those with severe cardiac dysfunction. Echocardiogram uses sound waves to check the heart's chambers and valves. The echo sound waves create a picture on a screen when ultrasound probe or transducer is passed over the skin over the heart. Echo can show damage to the valve flaps, backflow of blood through a leaky valve, fluid around the heart, and the heart enlargement. It is the most useful test for diagnosing heart valve problems. Electrocardiogram tests also be used to record the strength and timing of the heart's electrical activity. It shows abnormal rhythms, that is, arrhythmias or dysarrhythmias, and it can sometimes find heart muscle damage. Chest X-ray may be done to check the lungs and see if the heart is enlarged. Cardiac MRI also is done. It is an imaging test that takes detailed picture of the heart. It may be used to get a more exact look at the heart valves and heart muscles. Now we will see the treatment. The best treatment is to prevent rheumatic fever. Antibiotics can often treat streptococcal infections and keep rheumatic fever from occurring. Penicillin is the drug of choice. Missed doses of antibiotics due to the patient's unavailability while off the unit for diagnostic tests are given after returning to the unit. Missed antibiotic doses may have irreversible consequences. Notify healthcare provider if doses will be missed to make sure that appropriate alternative measures are taken. Prevention of recurrent episodes through long-term penicillin therapy for 5 years after initial attack in most adults are needed. With valvular damage, periodic prophylaxis throughout the life is given. People who have had rheumatic fever are often given daily or monthly antibiotic treatments. These can prevent infections from occurring again. They can also lower the risk of more heart damage. Anti-inflammatory medicines may be used to reduce inflammation and lower the risk of heart damage. To reduce inflammation, aspirin, steroids, or non-steroidal anti-inflammatory drugs may be given, and also to control the fever and pain. Other medicines may be needed to manage heart failure or abnormal heartbeat. Beta blockers, ACE inhibitors, digoxin, diuretics, supplemental oxygen, sodium and fluid restrictions to manage heart failure. The examples of beta blockers are atenolol, labetalol. Drugs ends with LOL. Examples of ACE inhibitors are captopril, enalapril. The drugs which ends with pril. Anticoagulants or blood thinners are given to the patient. It can reduce the risk of stroke or blood clots if client has a narrow mitral valve or atrial fibrillation. Examples are heparin, warfarin. Chorea is a jerky, uncontrollable movements of the head, arms, or legs. Though chorea is self-limiting, phenobarbital and diazepam may relieve the symptom. Rest is given to the patient to maintain optimal cardiac function. If the mitral valve is narrow but don't have other issues with it, a provider can perform a valvuloplasty to widen the valve. It is a minimally invasive procedure. If client has a severe rheumatic heart disease, client may need heart valve surgery. A surgeon repairs or replaces damaged heart valves. If they can't fix the valve, they can replace the damaged valve with an artificial valve or a tissue valve. In some cases, they may perform a Ross procedure, where a surgeon swaps one of the healthy valves for the damaged valve and then puts a new valve in place of the healthy one they relocated. What are the possible complications of rheumatic heart disease? It includes heart failure. This can occur from either a severely narrowed or leaking heart valve. Bacterial endocarditis. This is an infection of the inner lining of the heart. It may occur when rheumatic fever has damaged the heart valves. Complications of pregnancy and delivery due to heart damage. Women with rheumatic heart disease should discuss their condition with their healthcare provider before getting pregnant. Another complication is a ruptured heart valve. This is a medical emergency. It must be treated with surgery to replace or fix the heart valve. Other complications include cardiomyopathy, atrial arrhythmias, pulmonary and systemic embolism. Rheumatic endocarditis is prevented through yearly and adequate treatment of streptococcal infections. A first-line approach in preventing initial attack of rheumatic endocarditis is to recognize streptococcal infections, treat them adequately, and control epidemics in the community. A key nursing role in rheumatic endocarditis is teaching patients about the disease, its treatment, and the preventive steps needed to avoid potential complications. After acute treatment with antibiotics, patients need to learn about the need to take prophylactic antibiotics before invasive procedures.